Welcome, everyone. It is my pleasure to introduce the session, The Value of Play Therapy for Younger Children. Please feel free to ask your questions during the presentation in the Q&A area, and we will answer them during the presentation, or the presenter will answer them later and we will post them to our website. I'm Stephanie Mullet, and my son Bryce had a liver transplant in 2018, and I am a board member for the transplant families. I'm honored to welcome licensed professional counselor and registered play therapist, Kelsey Rogers from Children's Medical Center in Dallas, Texas. Thank you and enjoy.
Hello, transplant families. I'm going to be talking today about play therapy and what that looks like in the hospital setting. So my name is Kelsey Rogers. I'm a clinical therapist at Children's Health of Dallas on the solid organ transplant team. I'm a licensed professional counselor supervisor, a licensed marriage and family therapist, a registered play therapist, a trauma-focused CBT therapist, and an OPT-PLAY certified therapist. So on today's agenda, we're going to talk about what is play therapy, how do you become a play therapist, who's qualified to do that, what this looks like in the hospital setting, and then a little bit about child life versus play therapy. We often get confused, so I'm hoping to clarify some people's questions. So what is play therapy? So the Association for Play Therapy defines play therapy as the systematic use of theoretical model to establish an interpersonal process wherein trained play therapists use the therapeutic powers of play to help clients prevent or resolve psychosocial difficulties and achieve optimal growth and development. So that's a bit of a mouthful, so we're going to break that down. So Albert Einstein once said, "Play is the highest form of research," which I truly believe. Play is a crucial component in a young child's overall growth as it relates to the 5 domains of development. So physical, cognitive, language, social, and emotional development. So through exploration, discovery, and opportunities to create and grow one's imagination, play fosters many learning experiences. So just like adults utilize talk therapy, kids utilize play. Play is their form of language. And so specifically in kiddos who are much younger, who maybe have speech delays or maybe even selective mutism, play is a great way for them to express themselves. Play therapy can be used to help address a wide range of concerns, including but not limited to attention deficit disorder and hyperactivity disorder, toileting concerns, so constipation, enuresis, and encopresis, trauma and medical trauma, divorce, conduct disorders, social anxiety, bullying, and general behavior concerns. Research suggests that play therapy is an effective mental health approach, regardless of age, gender, or the nature of the problem, and works best when a parent, family member, or caregiver is actively involved in the treatment process. So when I say caregiver, that could be a home health nurse, that could be a foster care parent, or a family member, extended family, cousins, whoever that might be, who's involved in the child's life. How do you become a play therapist? I think it's commonly confused for, well, my kid can just play at home, right? So you are required to have a master's or doctoral degree in psychology or a related field. So for example, I have a Master of Science in Counseling. You're required to have an LCSW, so be a licensed clinical social worker, an LPC, a licensed professional counselor, an LMFT, a licensed marriage and family therapist, or have your PhD, or even your MD. We actually have a psychiatrist here who is a registered play therapist. You're also required to have 150 hours of play therapy education classes, often done while you're in grad school, but it can be done outside of graduate school. Minimum of 350 direct patient contact hours. So that means one-on-one patient care. And 35 hours of supervision. So having a registered play therapy supervisor supervise all of your contact hours. So what does this look like in the hospital setting? So here on the right is a picture of one of our play therapy rooms here, and I'll go into more detail about what is in a play therapy room, why we have certain items. So as licensed individuals, we often complete a mental health assessment or a health and behavior assessment prior to the first session, so often referred to as an intake. We're asking things about sleep, eating, behavior, school, family stressors, things like that, to really get a full picture of what's going on, because we know that your kid is more than just their diagnosis. We'll also get a PEDS QL or do a BASC, so a measure to kind of look at behavior and quality of life prior to starting play therapy sessions to kind of give us a baseline of what we're working with. We'll share those results with you, and then we often retest kind of halfway through the process. So typically sessions are done 2 to 3 times weekly while a patient is admitted, and once weekly once they're discharged. We really try and take advantage of the fact that they're here and they need support. So trying to see them 2 or 3 times a week is ideal. Sometimes we see them more than that, depending on what's going on. We work very closely with the other disciplines like child life, OT, PT, and speech. So occupational therapy, physical therapy, speech therapy, and then music therapy, social work, and our chaplains, also known as pastoral care. So what that looks like is oftentimes if a kid's here for a really long time, we know that routine is really beneficial. And so we sometimes put them on a schedule to help them know who's coming, what they're going to be doing, kind of give some predictability to this kind of chaotic environment. While the patient is admitted, we will either bring a bedside intervention kit. So I have like a little tub of different toys and items that I'll bring. Sometimes it's Play-Doh, smelly markers, Legos, doctor equipment, books, things like that. Or if we can, we'll try and bring them down to the transplant play therapy room. So what is in a hospital play therapy room? It's different from the child life playrooms. Child life has a lot more interactive activities that maybe make sound, or they have TVs, Xboxes. There's other kids in the room. When a kid comes for play therapy, it's just them and the therapist, sometimes a caregiver as well. So this is a kind of just an example I found on the internet of kind of a really well-equipped play therapy room. So we have things like art supplies, so paint, markers, beads to make necklaces, things like that. Sensory materials, so sometimes we'll have different squish balls or stress balls, or things like bubbles that they can use to help calm down. Dolls and puppets. You can see on the right in this picture, there's some dolls and puppets for imaginative play. Dress up is really great. Playhouse and a kitchen. Miniature figurines, so things like little animals, cars, trucks, people, things like that. Board games, so Operation, Trouble, Chutes and Ladders, things like that. Musical instruments, bop bag, often called Bobo in our playroom. It's a big red bop bag that they can punch, tackle, kind of get that cathartic display of aggression. And then sand or sand tray. Sand is a really great way for kids to process, and it's especially great for my really anxious kiddos. It's very mesmerizing and therapeutic. Pretend doctor equipment, but we also have real doctor equipment. So we'll have things like NG tubes, oxygen masks, bandages, empty test tubes, things like that, stethoscope, blood pressure cuff, things that your child might see when they're in the hospital. We also offer child-parent relationship training. So not every play therapist is trained to do this, but most are familiar. It's for ages 3 to 10, but it can be kind of redesigned for older kiddos or even younger. It's a 10-session protocol or manual for inpatient or outpatient. I've started it while the kiddo's been inpatient with the parent, and we continue it once they're outpatient. So the purpose behind it is providing an opportunity for caregivers to really reconnect with their child and foster healthy attachment. This can help reduce child behavior problems, stress in the parent and child relationship. Oftentimes, one of the parents becomes the default parent. They're the ones that are holding them for pokes and lab draws, and they become the bad guy essentially. And so this is a great tool to use to help rebuild that relationship. So we would be teaching you how to use some of the play therapy skills at home, and create your own special play times. So I'm going to go into what's the difference between child life and play therapy. So a child life specialist is a certified child life specialist. They focus and process of play to master developmental milestones and cope with stressful events. It's more short term, just while they're here in the hospital or maybe when they're here in clinic. They see ages 0 to 18, and it's much more directive, and I'll talk more about that. They focus on child development theories. Certified child life specialist is trained in child development. Immediate medical stressors, so things like lab draws, pokes, going into pre-op or post-op, getting an NG tube, things like that. Developmental agendas and goals, and then it's much more open format. So they have a maybe more broad range of things that they will focus on. The play therapist is a licensed mental health professional. So they address basic and persistent behavior issues and concerns, long-term. So typically I can see a kid anywhere from, a few weeks to several years, depending on the concerns. Typical ages are 2 to 12. Again, depending on their development, it could be younger or older, more non-directive. So when they come to a play therapy session, they get to be the boss while they're in there, within reason, of course. We only set limits when they're needed. So for safety concerns or things like that, it's based on a counseling theory. So some use theories like Adlerian or cognitive behavioral therapy, and they use that to kind of create their assessment of the room. Trained registered play therapists, they're trained in mental health counseling. It's long-term, and they focus on medical trauma and coping specifically for this population. There's broader dynamics, treatment agenda, and it's more closed format, really focusing on the mental health aspect. So a child life specialist is doing therapeutic play. So I know that can be confusing, so I'll get into that. So preparation for procedures and surgery, like I talked about earlier, NG tubes, surgery, CT scans, MRIs, things like that. So that procedural support, difficulty coping with hospitalization, diagnosis education. So they're oftentimes the ones that are helping the surgeons or the doctors talk about the new diagnosis. Therapeutic or medical play. So sometimes they'll bring equipment to the room to allow the kid to process, look at it. They'll educate them on what it is, what might be happening, what steps are about to take place. Non-pharmacological pain management techniques, using distraction or things like that to help them cope. Pill swallowing education, parenting and caregiver concerns. They talk about development and things like that. School reentry. So maybe your kiddo's been out of the hospital for 6 months to a year, helping them prepare for what school might look like. Sometimes the child life specialist will even go to the school or create a presentation to educate the classmates about what's going on. Sibling support. So maybe the parents are worried about how the sibling might cope with seeing their brother or sister in the hospital, helping prepare them for what they might see. And then grief and bereavement support, they help with end of life issues as well. And then play therapy, you're focusing on difficulty coping and adjusting to the hospitalization or illness, the anxiety surrounding the hospital and medical staff, parent training and support, like I talked about, that CPRT, medical concerns coupled with pre-existing psychological concerns, behavioral issues, adherence concerns. So maybe the kiddo's really having a hard time taking their medicine or refusing, blood draws or things like that, kind of helping create a plan. Family play sessions, so including the parent or maybe sometimes even the sibling in the session, depending on what's going on. Processing of diagnosis and medical experiences, implementing coping plans, and then weekly outpatient appointments. So child life will often defer to play therapy when they feel like it's reached a point where this is more of a psychological or mental health concern. and we'll collaborate together. And I'll talk about a case of where that happens. So this case example, 7-year-old boy diagnosed with hepatoblastoma requiring a liver transplant. So initially he coped well with pokes and hospitalization, but after weeks of being admitted, they started to refuse staff members, so telling him to go away, becoming very agitated when anyone in a hospital gown came in or scrubs, cried and swatted away medicine when they typically used to take their medicine really well. And the patient would have more outbursts and had a difficult time regulating emotions. So child life is often the first line of defense that goes in. So child life was consulted to assist with medication management and IV support and provided procedural support for this kiddo who ended up needing an NG tube. But the child life specialist noted that the behavior was not getting better and it was worsening, and this really presented more as medical trauma at this point. So the CL reached out to play therapy to collaborate. So I completed an intake with caregivers like I talked about earlier. So mental health behavior assessment. I did a PedsQL looking at the quality of life and how we felt like the hospitalization was going. I selected toys for our first bedside session. So I grabbed things like medical equipment, smelly markers, Play-Doh, some Uno cards, Connect 4, and a couple of books that I like to use. So initially, the patient wanted nothing to do with me. Very fearful when I came in the room, screamed, didn't want parents to leave, which is all very appropriate. And so I offered kind of the olive branch, like, how about I just sit with you and you can look and see what I brought. I don't have to play with you, but I thought you might want to look inside my bucket. And then, he kind of creeped over and looked in the bucket to see what I brought because he was curious. And I sat for about 10 minutes and then he kind of was agitated again and wanted me to leave. And I said, okay, well, I'm going to come back tomorrow and try again. So it took a few sessions, but eventually he trusted me and realized I wasn't a nurse. I wasn't a doctor. I wasn't someone that was going to hurt him or poke him or make him do something he didn't want to do. And our sessions ended up being 30 to 45 minutes. He often didn't want me to leave. He wanted me to leave the toys, or he wanted the play session to go a little bit longer. And he directed the play. And he was observed to exhibit themes of mastery and control, which is super common for kiddos who are here for long periods of time and who have had a chronic illness, because they're told what they can and cannot do all day, every day. And for a young kid who was previously independent, going to the bathroom on their own, sleeping in their own bed, that's a really big adjustment. So he was trying to control what he could, which is what I usually see when kiddos become very anxious in the hospital. They start to control things. So controlling what they eat, controlling who's in the room, controlling who talks to them, things like that. But eventually he started to use some medical equipment and pretended to be the nurse or the doctor, and I was the patient, and he very much led that experience and really showed me through his eyes what he perceived things to be or how he felt like things were going. And after a while, the parents and staff noticed a reduction in the outbursts and the mood swings. So he had the opportunity to express himself. I never corrected him. I validated his feelings, reflected his feelings. I would highlight, when he was feeling frustrated. But I would also highlight, when he was trying something new or that was difficult and he didn't give up. And it kind of became his mantra. So he eventually built self-confidence, and which in turn helped reduce some of his anxiety. So at the top picture here, you'll see a child life specialist. You can see he's kind of directing the play, showing the boy where the G-tube button is and what might be happening in the next procedure. Whereas at the bottom is a play therapist. They're more observing. They're not quick to necessarily start touching all the toys that the kid gets out. They're letting the child lead. And if they're invited to play, they will play. But oftentimes in the first few sessions, we're just reflecting what we see and validating how they're feeling and helping them draw, connections between their feelings and what they're going through and how to cope with those feelings. But oftentimes we're kind of sitting back and observing to see how they're coping. So these are some books that I often recommend. So The Whole Brain Child is a really great one. I like to use that, really looking at the development and kind of what's going on in their brain. How to Talk So Kids Will Listen and Listen So Kids Will Talk. So different parenting strategies. Brainstorm is a great one for teenagers. It's called Brainstorm, The Power and Purpose of the Teenage Brain. So it really talks about the storm that's going on inside a teenager's brain. The Invisible String I use for, I'll use it for grief and bereavement, but I'll also use it for separation anxiety. It's a really great book for that. The Color Thief, that's a great one if maybe the caregiver is experiencing depression and the kiddo senses that something's going on, but they're not sure what it is. The Rabbit Listened is one of my absolute favorites. So it really talks about how as parents and even caregivers, you just really want to fix it. You want them to feel better. And sometimes all they need in that moment is for you just to sit with them and validate how they're feeling, and let them work it out on their own. Wilma Jean, The Worry Machine. That's really great for my super anxious kiddos who ask a million questions, want to know all the details, and helping them identify what they can control and what they cannot control. The Princess and the Fog. This is great for kiddos who maybe are experiencing depression and aren't really sure what's happening in their brain or why they feel the way they do. And then No Drama Discipline is my other favorite book. It's a great one if you're not quite sure how to discipline your kiddo. I highly recommend it. These are some of the resources. I'd also like to highlight Sarah Lofton. She's one of our clinical therapists and play therapists here at Children's, and she recently wrote a journal article about child-centered play therapy and chronic illness, if anybody's interested. I really appreciate you giving me this opportunity to talk and educate. I'm sure I could go on for hours, but really wanted to get to the meat of what I think all the questions are. And I'd love to hear questions, concerns, and really talk about this further. So thank you.
Thank you so much, Kelsey. Is it okay if I ask you a few questions and then
Yeah,
we record
absolutely.
that at the end here? Yeah, we
Yeah.
might as well. We'll go ahead and I hope that it'll take this. Let's see. All right. How can I effectively introduce play therapy to my child to help them communicate their feelings after we're out of the hospital?
Great question. So hopefully if you can get a play therapist that can offer CPRT, having those one-on-one special playtimes at home go a long way. That undivided 30 minutes once a week. Oftentimes we tell parents to kind of have like a date card so it feels like an appointment, and you and the kiddo collaborate on the day and time. You'll set up a box of special toys and items. You don't necessarily have to go buy anything. You can even find old toys that are in your house that your kid doesn't play with anymore. Kind of put them in a tub for that special playtime. And so you only bring them out during that time together. Cell phones get put away. The other siblings hopefully can go somewhere else. You find an opportunity just to really get to see the world through your kids' eyes. You let them lead. Even if they're like, that block is orange, you don't need to correct them and say it's blue. Just letting them kind of process and play it out. Another book I love is called Not a Box, and it talks about how we're very quick to label things as adults. And it could be a rocket ship, it could be a space car. So in those 30 minutes, really letting them lead and show you kind of what's going on in their world. And then after those 30 minutes, absolutely, you can educate and do all those things. But in those 30 minutes, letting them be the boss and connect with you in a different way. I think we're very distracted nowadays with cell phones, TVs, and just life. So if you can set aside 30 minutes each week with your kid, it goes a long way.
Absolutely. And well said. I just thought a little bit of time goes a long way, doesn't it?
That's why I was saying this can even adapt to teenagers, just taking them to a coffee shop for 30 minutes or take them to go get, I don't know, a new book and go together and talk and put the phones away. They're more likely to tell you things in that moment than other times. So
certainly true. I've got one more question for you.
yeah.
Let's see. Are there some common challenges younger children face in expressing their feelings about medical procedures like transplant? And is there common things that you usually see in your practice?
Yes. So I think, especially in the younger age group, they're still learning feeling words, what it feels like to have those feelings. Frequently, I have kiddos that confuse the word mad or frustrated with feeling sad. And so I think it's really crucial. We try very hard here in transplant between child life and psychology to really help them identify what they're feeling so we know how to support them. Sometimes kids will be like, I'm really frustrated. And I'm like, I wonder if you're feeling sad, because tears are rolling down their face, and helping them identify and helping them also realize what their available coping mechanisms are. Like, do you think it would help if you had a hug from mom or dad? Or do you want to squeeze a stress ball? Do you want to blow some bubbles? Do you want to read a book? Kind of helping them realize what their coping mechanisms are. Do you want to take some deep breaths? But I think a lot of it has to do with the younger age group not knowing what those feelings are and how to communicate them. So a lot of times we'll also see them act out more, throw things, have tantrums, yell at people, things that maybe aren't normal for them or part of their typical personality. You throw steroids and all those other things on top of it, and you have a very different child. And so our job too is to help educate parents on, this is typical. This is not, forever. Your kid's going through something. So it's really figuring out what they need in that moment. As I say, kids are not manipulative, but they'll find a way to get their needs met. And so it's helping them figure out what they need in that moment. I don't know if that answers your question, but okay.
It certainly does. And thank you for that. As always, I'll give the disclaimer and I'll let you add on what you'd like. Yes. If you're having play therapy at home and you hear anything to the effect of, I wish I wasn't here anymore, or things like that, you need to call your transplant team or 911 immediately.
Yes, go to the nearest emergency room if you live near one. And there's also different crisis hotlines you can look up. NAMI has some great ones, and definitely alerting your transplant team to any of those types of concerns.
This has been so amazing, and thank you for covering this very difficult topic.
Thank you for having me.
Yes, we're so grateful to have you, and hopefully we can have you back, because I see a number of other topics that we could probably cover at some point.
I'm sure. That's why I was like, I could go on for hours, but I tried to condense it.
Thank you so much, Kelsey.
Thank you.
Any questions from the audience, please direct them to hello@transplantfamilies.com, and Kelsey will look at the list afterwards and we'll send that back out in a future blog. Thank you all so much.
Thank you. Have a great day.